Yes, last time we discussed about the first part of the Uveitis, all the development, signs, symptoms, and things. Today we will discussing the all lab investigation, differential diagnosis, and best part of the treatment of this. Before that, I'll ask you one or two questions. Please don't talk. What are the main signs of acute uveitis? Main signs, slit lamp examination, so that you can diagnose this is acute uveitis, acute iridocyclosis. Two main signs. There are so many, but important ones so that you can diagnose. Anyone. Two important signs. Don't look into the books. So that immediately that comes in your mind. Nobody? Yes, now I ask you. What is KPs? No one. And what is flare? These things I taught you in the last lecture. These two important signs, slit lamp examinations, these are the diagnostic features. If you see under the slit lamp with the slit, KPs. KPs means proteinous cellular exudates deposited at the back of the cornea. Because in the examination, many times you get the short note also, in the viva also, we can ask you, what are KPs? So these are proteinous cellular exudates deposited at the back side of the cornea. There are so many types. Button side KPs, fine KPs, red KPs, crenated KPs, healed KPs, or these are the KPs. So these are the KPs. If you under the slit lamp, if you see white part, I'll show the picture that. Last time I'll show you. White dots like structure at the back of the cornea, the endothelium, they are deposited, especially in the lower part of the cornea. So these are KPs. These are the cellular deposits, proteinous cellular deposits. From where they come? They come from the capillary permeability because of the inflammation comes in the AC and deposited at the back of the cornea. This is one important sign of the uveitis. The second is the aqueous flare. What is flare? Protein materials, they are suspended in the aqueous. Protein is part because of the inflammation or the capillary permeability changes, and this protein material comes. Cell also comes, but important is the protein material that is suspended. You know the Tyndall's effect, through the window light comes like suspended particles. That is the aqueous flare. Depending upon the quantity and the severity of that, 1 plus, 2 plus, 3 plus, 4 plus. And clinically, if you can see the details of the iris and the lens, that is 1 plus. Or the lastly, if you cannot see anything, so that is the aqueous flare. So these two are important. Other signs are all ciliary congestion, synecdoche, or the hyphema, like that. There are other features. But important thing is these two features so that you can diagnose this is a case of acute uveitis, iridocyclosis. Okay, once we have diagnosed, then we go further. What are the investigations we have to do under the size treatment part or differential diagnosis and this thing that we are discussing today. Investigations. Almost every disease is causing the uveitis part. Every disease. There are some features, some investigation that you must do that just to diagnose because there are certain features. Come there. Like blood cells, TLC, DLC, ESR, blood sugar level, uric acid, serological tests, they are syphilis, toxoplasmosis, histoplasmosis, then anti-nuclear antibodies, RA factor, Ali cell phenomena, C-reactive proteins, and the streptolysin O. Urine test, we also RBC or for blood. Stool examination for the ova and cyst. Radiological examination is also very, very important, especially of the sacroiliac joint and the X-ray chest and the lumbar lesion, sacroiliac or lumbar lesion. Skin test, tuberculin, cream test, and toxoplasmosis test. Almost these are the investigations. These are the normal investigations. We must do that. I ask you, just you see that ESR I have written here. Why we want ESR? What do you want? Anybody? TLC, okay, some inflammation or like that. That is, if we want to know that whether the inflammation is acute or chronic or like that. Why we want ESR? Because the raised ESR, that shows there is some chronic infection is there. Especially in which infection? By now you must be knowing that. There is one inflammation, one infection of the lungs. That is tuberculosis. ESR is raised very much high. So we'll have a clue. Suppose ESR is very high, we'll have a clue that some inflammation, sorry, some part of the inflammation is there. That is what. Stool, why we want? Because ova and cyst, we want to see that. That is any parasitic infection. That we want to know. Other tests, sugar like syphilis, toxoplasmosis, all these things. Almost these investigations routinely we are doing if a case is coming to you as the acute uveitis part. These are the must things. Okay, differential diagnosis of the red eye or the acute iridocyclitis. The glaucoma part is covered in the theory part. What happened? Glaucoma is covered or not in your theory lectures? No answer, yes or no? No. Okay. So I'll skip this part because the glaucoma is, when a case of the red eye comes, there are three main causes of the red eye in the OPD like that. Come. One is the infection, like acute conjunctivitis. One causing red eye. Other factors also there, trauma and chemical injury. These are the three common causes of the red eye. One is the conjunctivitis, acute conjunctivitis. Another is acute iridocyclitis that we are discussing today. And third is the acute congestive glaucoma or the narrow angle glaucoma. These all three causes the red eye. So we have to differentiate. Whenever the patients come in the OPD having the red eye, complaining, I am having pain. So these three things, this must come in your mind. It can be conjunctivitis, it can be acute iridocyclitis, or it can be acute congestive glaucoma or narrow angle glaucoma. Because the angle glaucoma, the glaucoma is not covered to you. So I'll skip some part of this, some salient features I'll tell you. Suppose that case comes to you in OPD, is sitting in front of you, red eye is there. We have to diagnose whether this is conjunctivitis, whether this is iridocyclitis, or whether this is narrow angle glaucoma or acute congestive glaucoma. Salient features. You ask 2-3 questions. First, see that patient. Congestion is there. Congestion can be in all the cases. First, you ask whether the discharge is there, mucopurulent or purulent discharge is there or not. If patient says yes, too much discharge is there, my eyes are sticky or like that, this is going towards acute conjunctivitis. Pain is less discharge is more, congestion is there, diminution of vision will be less. Because of the discharge that comes in front of you, that is patient, there will be no diminution of the vision. If you can touch that, try to touch that, tension, digital tension is high. This goes toward the favor of glaucoma. If the patient complains of diminution of vision is there, you can check the vision also. If diminution of vision, more in favor of uveitis part. That history you have taken. If there is any history of vomiting or pain or acute exacerbation, more in favor of congestion, whether acute congestive glaucoma, because the tension is more than 80 or 60 that will be in favor of that. Go under the slit lamp, patient. You see the patient. Under the slit lamp with the slit, if the pupil is normal, AC is normal, only discharge, the redness is there, that is conjunctivitis. Second case, uveitis, if the pupil is festoon shaped, synecia is there, KPs is there, or the aqueous flare or cells are there, more in favor of uveitis. Remaining is the glaucoma, if the pupil is vertically oval, not reacting, AC is very shallow, tension is high, patient is diminution of the vision, more in favor of glaucoma, acute narrow angle glaucoma. That is how we can diagnose. Why we want this practically or this clinically? Because if the conjunctivitis case is there, you have to give antibiotic, plain antibiotic, no steroid required the conjunctivitis, except some selective nular or allergic conjunctivitis. Uveitis case treatment will discuss you, but that requires a steroid. We will start that. If the narrow angle glaucoma, that requires hypotensive drugs, timolol or primolol or latanoprost or like that. Hypotensive means lower tension decreasing drug. Suppose in case of glaucoma, narrow angle glaucoma, if you start dilator, means atropine or home atropine or like that topicamide, patient will flare up the condition, tension will be more high and tension will be more, because that will occlude your angle. More tension will increase. So that is contraindicated in narrow angle glaucoma or any glaucoma cases. Or suppose in uveitis cases, you have not started glaucoma, just steroids, patient will not respond of that. That is why these things are important. First you diagnose, then depending upon you have to start the treatment. Because in the uveitis, this dilator plus steroid are must. And dilator and steroid is contraindicated in glaucoma cases. And in conjunctivitis, there will be no response like that, but you should not start. Plain antibiotic you should start. That is why all detail, there are so many points because the glaucoma is not treated. I have salient features, I have told you that. These are the some diagnostic features of this. So I leave this point, now we will come now. This is the, I think last time I have told you pathological uveitis classification, we have done that. Granulomatous uveitis and the non-granulomatous uveitis. As the name indicates, granulomatous acute idiopathic or uveitis means whether the granuloma or tubercles are formed. This is a chronic infection, chronic part. Non-granulomatous, this is mostly the allergic part. So we have to differentiate these things. Causes of granulomatous uveitis, because this is infective. Can you think of what can be the causes of granulomatous uveitis? Infection, common infection, just like syphilis, tuberculosis. Some allergic parts, sarcoidosis or the sympathetic ophthalmitis. These are the infective parts. Non-granulomatous, allergic in nature, Behçet disease, idiopathic, this is arthritis. These are some part of some infection. Ankylosing spondylitis, this is acute in nature. These are allergic part. So allergic means non-granulomatous. Infective means granulomatous. But there are some exceptions. Like there is one leptospirosis infection. This is the infection. It should be in granulomatous part. But there is a severe reaction. Features are just like non-granulomatous. Redness, capes, pain and like that. In the other way, allergic part, just like sympathetic ophthalmitis. Allergic means non-granulomatous, but that is granulomatous, that is a reaction to someone else. So these are some variations of that. But commonly, infective is the granulomatous, other part is the non-granulomatous. So we have to see that by seeing the cases of the granulomatous and the non-granulomatous uveitis part. Two sides I written here. This is the all features of non-granulomatous and these are the all features of the non-granulomatous. We can differentiate dramatically. One by one I will tell you. These are the sum because many times in the theory part of the practical examinations and that we can ask you what are the differences of the granulomatous, non-granulomatous uveitis. Suppose the case is given to you and you have seen all the features, you are explaining that these are the features that. We'll ask you now, depending upon your feature, depending upon your finding, which type of uveitis this is. Whether the granulomatous or the non-granulomatous. So these are the some features. Take one, onset. Granulomatous is insidious or the slow or the chronic insidious onset. Non-granulomatous is acute because it is acute in nature. Pain will be minimum in granulomatous and the marked in non-granulomatous. Photophobia will be less in granulomatous and all features are insidious in granulomatous part. Important thing is the ciliary congestion, minimal congestion in granulomatous while the marked in non-granulomatous because this is acute. KP, which I asked you earlier, these are the fine proteinous cellular exudate. Mutton fat KP means most the size will be more than white part. These are the mutton fat KP. Size is bigger. These are the small size. These are the small KP. These are the mutton fat KP. Tubercles. This is in the granulomatous. Tubercles is the less in non-granulomatous. There are some diagnostic features of this. So the KPs will be mutton fat KPs in granulomatous, while the fine KPs or small KPs in non-granulomatous. Aqueous flare will be mild in granulomatous, marked in non-granulomatous. Iris nodules usually present in the granulomatous because the syphilis or tuberculosis, fine nodules or the tubercles will be fine, while they will be absent in non-granulomatous. Posterior synechias will be very thick in granulomatous. And these are the thin and tenuous in non-granulomatous. Fundus examination, nodules can be seen in granulomatous and while no or diffuse involvement in the non-granulomatous. By seeing all these features, we can say that non-granulomatous is acute in onset, more troublesome, more pain, redness is more, diminution vision is low, decrease. That is the non-granulomatous acute. Generally allergic in nature. Generally allergic. Why I use the word allergic generally? Because there are other features also there. Transitional zone. Common causes of the non-granulomatous in young age uveitis, ankylosing spondylitis. Important finding that. Or other reactions. But that is the more common. Behçet's disease. These are allergic in nature, but they are acute in nature. And granulomatous, tuberculosis, syphilis. These are the infective parts. But allergic is sympathetic ophthalmitis or sarcoidosis, like that. These are also infective. These are non-infective in nature. Now, by seeing this is clear that these are the features of the granulomatous and these are the features of non-granulomatous. Suppose there is a case where we cannot see or we are not able to see the tubercles. Other features are there, mutton fat capes are there, thick synechias are there, insidious onset is there. We will suspect the granulomatous part. Whenever the granulomatous part of uveitis comes, think about 2-3 things: syphilis, tuberculosis, sarcoidosis, and sympathetic ophthalmitis. So these are the granulomatous part. Granulomatous means granuloma or the tubercles we can see either in the choroid, either in the iris, either in the retina, or like that. Then you will say the granulomatous part of this one. That is important part of this. Whenever the uveitis comes, a case, suppose you are diagnosed, sir, this is a case of uveitis. Two things, whether acute uveitis, or the chronic uveitis, or the recurrent uveitis. Acute means sudden onset, chronic means 3 months duration, recurrent means coming again and again. Once you have diagnosed this is uveitis, then we will ask, this is granulomatous or the non-granulomatous. This is infective or the non-infective. So that we have to see that with mutton fat capes, fine capes, tubercles, synechias, redness, the pain is there, dimness is the vision, or like that. Accordingly, all investigation you go through so that you can pinpoint the diagnosis part. That is the granulomatous, non-granulomatous, and differential diagnosis of this uveitis part. Once we have seen that all features, how we treat such type of the patient. Standard treatment of the uveitis, whether this is granulomatous or the non-granulomatous, something that we have to start immediately. Local therapy, mediated cycloplegic drugs, steroids, and the broad spectrum antibiotics. We can start the systemic also, physical measure, specific treatment course, and treatment of the complication of that. Two things important in the uveitis part: steroids and dilators. We have to start in all the cases. Mediatics in dilator. You should know what are the dilators, what is the mechanism of action, what is the duration of the actions of all these things. Mostly the dilators in the uveitis we are taking part using atropine, home atropine, cyclopentolate, and topicamide. Maximum duration of the action is of which drug? Anybody can tell? What is the maximum duration of action of the dilator? Any drug. Which drug? That is the atropine. 10 to 12 days. Once you have started atropine, that effect will remain for 10 to 12 days. Home atropine, 3 to 7 days. Cyclopentolate, topicamide, and like that. Less duration, but they are dilated. Then two things are there. One dilator is the dilator, but not the cycloplegic drug. Do you know what is cycloplegia? A loss of accommodation, ciliary body paralysis. That is the phenylephrine not causing cycloplegia. Other all drugs are causing cycloplegia. Okay, we'll start the all dilator, that atropine, home atropine. Mode of action, the atropine. 3-4 actions are there. Gives rest to the eye, relieving the spasm of the eye sphincter, ciliary body, prevents synecdoche formation and the break synechia, reduces the exudation and decreasing hyperemia and vascular permeability, increase blood supply to the anterior uvea by relieving the pressure on anterior ciliary artery. Now all the dilator, relieving spasm, breaking synechia, and prevent synechia formation, more this blood exudates to the drugs to the interior. These are some mechanism of action of the dilator. That is why we are starting that. Corticosteroids, topical as well as systemic drops also we are starting. Topical is the these are the corticosteroids are anti-inflammatory, anti-allergic and anti-fibrotic agent. Remember that. We'll ask you what are the signs or these corticosteroid causes. What are the features of the corticosteroids? So corticosteroids are anti-inflammatory, anti-allergic and anti-fibrotic also. This is the three mechanisms, three actions of the steroid. Every steroid will start this. Then we will start that. These are the dexamethasone, betamethasone, hydrocortisone or the prednisolone. We can start topical drugs all depending upon. Systemic also we can start all the dexamethasone or prednisolone like that. Some specific indications of the systemic steroids. 3-4 indications. If we have started topical drops steroids, not responding. Bilateral uveitis, will start this steroid. Posterior uveitis in the case, will start the steroid. Or recurrent uveitis, will start the steroid. So remember this. First you start the topical steroids. If they are not responding, give bilateral. That we have to start. We have to see that whether the indication is there or not. Broad spectrum antibiotics, so many antibiotics, getafloxacin, moxifloxacin, chloramphenicol, topramycin, that will start. With this steroid, we start the antibiotic drops also. Then comes the immunosuppressive drugs. These drugs should be used in serious cases or where the steroids have failed to resolve inflammation and danger of blindness. These drugs are dangerous but should be used with great caution in the supervision and hematologist and with oncologist. These drugs are especially in cases of Behçet disease, young age, sympathetic ophthalmitis, pars planitis and VKH syndrome. These diseases, they require maximally the immunosuppressive drugs. That will start. Drugs used are cyclophosphamide, chlorambucil, azithromycin and methotrexate. Cyclosporin is also an anti-T cell drug but highly renal toxic. So that suppose you have started this steroid and patient is not responding, then we'll try these. Cyclophosphamide, immunosuppressive, these are azithromycin, chlorambucil or cyclosporin A, we can start. In special cases of the VKH, the pars planitis, sympathetic ophthalmitis, we'll start these drugs. These are the special indications of the immunosuppressive drugs. Treatment of the causes. Suppose by investigations we have seen that this is a case of tuberculosis having uveitis. Immediately you start the anti-tubercle drugs also. That is why a special treatment you will start. Like syphilis also, toxoplasmosis, then we start these if diagnosed. Otherwise, broad spectrum antibiotics and steroids, we have to start in all the cases. Treatment of complication. Suppose we have treated all these things, signs, symptoms and the features, investigation, differential diagnosis and the treatment we have started. Because suppose in the last time also I told you that question can become enumerate sequelae and the complication, how will you treat these cases of this? At the last of this one by one you see that inflammatory glaucoma. What is inflammatory glaucoma? We have seen. These are the inflammatory cells. They are deposited in the angle. That causes the raised tension, inflammatory glaucoma. How will you treat this? Try the anti-glaucomatous drugs, some hypertensive drugs, and anti-inflammatory steroids like that. That will be automatically. One. Post-inflammatory glaucoma, same part, more drugs, or at the last, if not treated, give the filtration surgery. Complicated cataract. Cataract is covered here in the theory part. Cataract is also not covered. If the complicated cataract causing the diminished vision and the patient is unable to work that, remove the cataract, implant the, and that will be treated. Choroiditis, retinal detachment, treat as a posterior segment surgeon or like that. Steroids and all these vitrectomy or like that. Papillitis, uveitis, all steroids and anti-inflammatory drugs. Thysis bulbi, the pain is there, remove that eye. These are things we have to do. Thysis means atrophic of the eye. So these are the complications of the uveitis, slowly, causing sequence-wise complications. Glaucoma, early, post-inflammatory, complicated cataract, detachment, choroiditis, papillitis, thysis bulbi. So accordingly, you have to treat that. So now we have known that what are the sign symptoms, what is the investigation, what is the differential diagnosis, how to treat that, and what are the complications and how to treat the complications. With this, that finishes your uveitis part of complete of this, up to the starting from the embryology to the last complications we have covered to you. Remember, this is important topic theoretically as well as practically also. So go through that. Also, this is a very large topic, but in brief, I told you almost everything there. Signs, symptoms, red eye, differential diagnosis, treatment, complication, and treatment of this. So please go through that so that you can reply also whenever anybody asks you some short question that you can reply that. Just I ask you what are the KPs, you were not able to do that. So at least you should know these some simple things. So go through that so that you will be ready to that. So that finishes your uveitis part. And next time we'll see that what topic we'll do.